A 35-year-old male presents to the surgical ER after a road traffic accident. On exam, we see a wound of about 1 by 1 centimeter on the medial aspect of his right leg. And the patient? He's completely unable to move that right leg.
To add to that, his right leg is pale, cold, insensitive to pain, and there are absolutely no palpable distal pulses. So according to the Castillo-Anderson classification, what's the category here? Are we looking at A, type 1, B, type 2, C, type 3A, D, type 3B, or E, type 3C?
The correct answer is E, type IIC. Okay, so this patient presents with an open lower extremity fracture complicated by a really critical vascular injury. We know this because of that pale, cold, pulseless limb. Under the Castillo-Anderson system, any open fracture linked with a major arterial injury that literally requires a formal vascular repair for limb salvage automatically gets slapped with the type IIC classification. The real pearl to take away from this vascular injury rule dictates the classification strictly based on the structural arterial damage. The physical size of that tiny 1 by 1 centimeter external wound doesn't change this designation at all.
Next scenario. We've got a patient presenting with high-energy trauma, specifically a car versus car highway accident. He sustains a comminuted fracture of the tibial shaft along with a 6 to 8 centimeter laceration, but there is an overlying skin flap present. Crucially, the distal neurovascular bundle is totally intact with normal pulse and movement. So which type of open fracture is this under the Castillo-Anderson classification? Options are A, type AII, B, type BII, C, type CII, D, type 1, or E, type 4.
The correct answer is A, type 3A. This is a high-energy injury with a comminuted tibial shaft fracture and a pretty extensive 6 to 8 centimeter laceration, which firmly puts it in the type 3 category. But because that distal neurovascular bundle is perfectly intact, we can rule out type 3C. It lands right at type 3A because despite the massive soft tissue damage, there is adequate local soft tissue and that overlying skin flap to completely cover the fractured bone after a thorough surgical debridement. Remember, type 3A has adequate coverage while 3B has inadequate coverage that's going to require a regional or free flap.
Moving on to a 20-year-old man who comes into the ER 6 hours after a motor vehicle accident with an open tibial fracture. He was traveling at 80 miles per hour at the time. The wound is 10 centimeters long, and it is highly contaminated, though, thankfully without any neurovascular injury. Which Castillo classification is most appropriate here? Options are A, I, B, 2, C, 3A, D, 3B, or E, 3IC.
And the answer is D, type 3B. This patient experienced a high-speed, high-energy impact at 80 miles per hour, which causes extensive periosteal stripping and muscle devitalization in the anterior tibia. Once we go in and do the necessary surgical debridement to remove all that non-viable tissue and clear out the massive contamination, there just won't be adequate local soft tissue left to cover the exposed bone. That absolute need for a regional rotational flap or a microvascular free tissue transfer is exactly what defines a type 3B open fracture. Keep in mind any motor vehicle impact over 37 miles per hour automatically triggers a high-energy classification, and whether or not you need a flap is determined strictly post-debridement.
All right, so what is the appropriate bony management in the case of a type 2A Castillo-tibial fracture? Options are A, plates and screws, B, external fixation, C, external fixation and flap coverage, D, intramedullary nail, or E, debridement and observation.
The correct answer is B, external fixation. A Castillo type 3A open tibial fracture means we're dealing with high-energy comminution, periosteal stripping, and contaminated soft tissues. If you place internal hardware, like massive plates and screws, directly into an acutely contaminated, stripped open fracture field, you run a massive risk of bacterial colonization, hardware infection, and chronic osteomyelitis. Because of that, external fixation is your go-to treatment in the acute phase. It stabilizes the bone perfectly while staying well away from the zone of injury, it protects the surrounding soft tissues, and it lets you do serial wound care. Your key exam pearls for external fixator indications include damage control orthopedics, stabilizing open fractures, temporary joint bridging, and managing infected non-unions.
Which of the following is a disadvantage of a self-tapping screw compared to self-drilling screws for bony fixation? Your options: A, increased risk of screw deformity or breakage while applying, B, increased risk of screw break during removal, C, increased risk of dislocation or loosening, D, increased risk of thermal damage, or E, all of the above.
The answer is E, all of the above. With self-tapping screws, you have to drill a pilot hole slightly smaller than the core diameter and then insert the screw so it basically cuts its own thread path right through the cortex. That generates a ton of friction at the screw-bone interface. And that friction doesn't just increase the risk of mechanical deformation and breakage, it also causes localized thermal necrosis of the bone. This thermal damage directly leads to osteoclast resorption, implant loosening, and eventually hardware failure. Self-drilling screws completely bypass these risks. They incorporate a built-in drill bit and that clears bone debris efficiently without needing a separate pilot hole, vastly minimizing that dangerous thermal necrosis.
Let's look at a pediatric case. A child suffers from a supracondylar fracture of the humerus and has been managed conservatively in a local hospital in his village. Which of the following complications would occur due to the malunion of a supracondylar fracture? Options: A. Cubitus varus, B. Cubitus valgus, C. Heterotopic ossification, D. Infection, or E. Neurological injury.
The correct answer is A, cubitus varus. A very common long-term complication of an improperly reduced or inadequately stabilized pediatric supracondylar humerus fracture is a malunion that results in a cubitus varus deformity. You'll often hear this classically called a gunstock deformity. This structural issue involves varus angulation in the coronal plane, hyperextension in the sagittal plane, and internal rotation of the distal fragment. To put that into perspective, the normal physiological carrying angle of the elbow sits between 5 and 15 degrees of valgus. Cubitus varus is defined as a carrying angle of less than 5 degrees, which shows up clinically as a medial deviation of the forearm.
Now, a 23-year-old patient presents with a lateral condylar fracture of the right humerus that was managed conservatively in an emergency setting. Which of the following deformities will result if improper fixation or non-union occurs in this specific case? Options: A. Cubitus varus, B. Cubitus valgus, C. Gunstock deformity, D. Osteonecrosis, or E. Post-traumatic arthritis.
The correct answer is B, cubitus valgus. This is a crucial distinction. Unlike supracondylar fractures, displacement or non-union of a lateral humeral condyle fracture directly disrupts the lateral growth plate. If this goes uncorrected, the progressive arrest of lateral condylar growth paired with the ongoing medial growth literally drives the elbow into abnormal lateral deviation or cubitus valgus. So remember, supracondylar malunions cause varus, while lateral condyle non-unions lead to valgus. Plus, over the years, this valgus angulation chronically stretches the ulnar nerve right behind the medial epicondyle, carrying a huge risk for a delayed neurological condition we call tardy ulnar nerve palsy.
Next up, a 39-year-old female presents with pain in her right forearm after a fall. On exam, we note severe tenderness in the forearm, but the neurovascular exam is unremarkable. Her X-ray reveals a fracture of the distal third of the right radius alongside a dislocation of the right distal radio-ulnar joint, or DRUJ. Which of the following correctly describes these findings? Options: A. Monteggia fracture, B. nightstick fracture, C. greenstick fracture, D. Galeazzi fracture, or E. Colles fracture.
The correct answer is D, Galeazzi fracture. A Galeazzi fracture is a very distinct injury that pairs a fracture of the radial diaphysis, usually right at the junction of the middle and distal thirds, with a dislocation of the distal radio-ulnar joint. This is famously known as a fracture of necessity. Why? Because the muscle forces acting on the forearm make closed reduction highly unstable, meaning it strictly requires open reduction and internal fixation to restore normal anatomy. Let's break down the matrix for these. Galeazzi is distal radius plus DRUJ dislocation. Monteggia is proximal ulnar fracture plus radial head dislocation. And a nightstick fracture, that's just an isolated mid-shaft ulnar fracture.
A 48-year-old female patient fell on an outstretched hand, and importantly, her palm was held in flexion during the fall. X-rays show a fracture of the distal radius with volar angulation. What's your diagnosis? Options: A. Colles fracture, B. Smith's fracture, C. nightstick fracture, D. greenstick fracture, or E. Monteggia fracture.
The correct answer is B. Smith's fracture. A Smith's fracture is an extra-articular fracture of the distal radius, characterized specifically by volar or palmar displacement and angulation of that distal fragment. This typically happens from a fall right onto a flexed wrist or from a direct impact to the dorsum of a flexed hand, which creates a clinical deformity we describe as a garden spade deformity. So a Smith's fracture gives you volar displacement like a garden spade, whereas a Colles fracture, which comes from a fall on an extended hand, gives you dorsal displacement, creating that classic dinner fork deformity.
A 34-year-old patient suffers a displaced, comminuted, middle third clavicular fracture following a road traffic accident. The treatment of choice for this fracture is options: A. Tension band wiring, B. Cement augmentation, C. Arm sling, D. Internal fixation with K-wiring, or E. Internal fixation with plates and screws.
The correct answer is E, internal fixation with plates and screws. Now, while a lot of clavicle fractures heal perfectly well with conservative management, a completely displaced, multifragmentary, comminuted midshaft clavicular fracture carries a very high rate of non-union and persistent functional deficits if we don't stabilize it properly. Open reduction and internal fixation is the gold standard approach here to aggressively restore length, align the bone, and allow for early shoulder mobility. Absolute indications for surgery include things like an open fracture, skin tenting, or neurovascular injury. Relative indications would be structural shortening of more than 2 centimeters or a complex floating shoulder injury.
On the flip side, a 30-year-old patient suffers from an undisplaced middle third clavicular fracture after a road traffic accident. The treatment of choice for this fracture is options: A. Tension band wiring, B. Intramedullary device, C. Arm sling, D. Internal fixation with K-wiring, or E. Internal fixation with plates and screws.
The correct answer here is C, arm sling. An undisplaced middle third clavicle fracture maintains a completely intact periosteal sleeve. That grants it absolutely excellent healing potential without needing to expose the patient to the unnecessary risks of an operation. Conservative management with a simple arm sling or a figure-of-8 bandage for 4 to 6 weeks is the standard of care. This brief period of immobilization is essential for comfort, but you must combine it with early shoulder pendulum exercises. This is absolutely crucial to prevent adhesive capsulitis, better known as a frozen shoulder.
A patient presents to you in the orthopedic outpatient department complaining of a claw-like hand. He mentions a history of a fracture a few months ago following a road traffic accident managed at a local hospital. Which of the following fractures is associated with the dreadful complication known as Volkmann's ischemic contracture? Options: A. Supracondylar fracture of distal humerus, B. Dislocation of shoulder, C. Diaphyseal fracture of radius, D. Undisplaced clavicle fracture, or E. Scaphoid fracture.
The correct answer is A, supracondylar fracture of the distal humerus. Volkmann's ischemic contracture is a truly devastating complication stemming from an improperly managed pediatric supracondylar fracture. It happens when unaddressed compartment syndrome, or kinking of the brachial artery, completely cuts off essential blood flow to the anterior forearm. This ischemia leads to deep flexor muscle infarction, essentially replacing vital muscles, like the flexor digitorum profundus, with non-compliant scar tissue. That fibrosis pulls the hand into permanent flexion contractures, giving you that characteristic claw hand deformity. To prevent this, you absolutely have to avoid extreme hyperflexion of the elbow past 90 degrees during casting, and persistently maintain a high index of suspicion for early compartment syndrome, because in orthopedic trauma, failing to look past the bone can literally cost a patient their limb.